Hello and welcome everyone. The topic that I am taking today is an important one, which is squamous cell carcinoma. It is important for the theory. Many a times the question comes like a short note. Then also very important for the practicals, as the slide is given in the spotting as well as in the practicals. So squamous cell carcinoma, you know that squamous cell carcinoma can be seen in the skin as well as in the mucosa, which is covered by the stratified squamous epithelium, like in the cervix, esophagus, vagina. All these sites, like anal canal, all these sites, they can have squamous cell carcinoma. And here I'll be discussing about the squamous cell carcinoma of the skin, which is also known as cutaneous squamous cell carcinoma. So cutaneous squamous cell carcinoma of the skin, it is a malignant neoplasm in which there is proliferation of abnormal keratinocytes. These are the cells of the epidermis of the skin, and it is the second most common tumor on the sun exposed sites, the most common being the BCC, basal cell carcinoma. It is more commonly seen in males. So males, they are more prone for SCC than females, and the fair skinned people, they are also at a greater risk of developing cutaneous SCC. Next we come to the risk factors which are important to know in case of squamous cell carcinoma of skin. So first and foremost is the exposure to the sunlight over long periods. When there is exposure to the sunlight, then there is DNA damage which is induced because of the ultraviolet radiations, especially the UVA rays, and they cause the damage to the DNA. And DNA damage will cause the proliferation of the abnormal keratinocytes. There are some precancerous conditions like actinic keratosis and Bowman's disease. Now, actinic keratosis, there are multiple plaque and papule-like lesions, and in Bowman's disease, there is a single erythematous plaque, well-demarcated plaque that is seen. And here you see this is a clinical picture of Bowen's disease, and there is a red scaly well demarcated plaque which is seen. And again in the microscopy, the full thickness dysplasia of the stratified squamous epithelium is seen in Bowen's disease, so that's why it is also called carcinoma in situ. The other lesion is actinic keratosis with multiple papule and plaque like lesions. These are the lesions again seen in the sun exposed areas, and in the microscopy the basal layer shows the dysplasia along with presence of orthokeratosis and parakeratosis, also hyperkeratosis. So these are the two lesions that you need to know in the as a risk factors for squamous cell carcinoma. Then chronic ulcers, they are also predisposed to develop squamous cell carcinoma. Immunosuppression is a very important risk factors. Immunosuppression, like in cases of people who are undergoing chemotherapy or who have undergone organ transplant. So they are prone to recurrent infections, and especially infection by the transforming viruses like human papilloma viruses 5 and 8. They have a risk of developing squamous cell carcinoma. Then industrial carcinogens like tar, oils, old burn scars, if they develop squamous cell carcinoma, then that condition is known as Marjolin's ulcer. So old burn scars or Marjolin ulcer, they can develop into squamous cell carcinoma. Many times question in the exams come on Marjolin's ulcer, then you have to describe SCC also in that. And then next is ionizing radiations. Next is a Kangri cancer. Kangri cancer, it is a cancer which is especially seen in cold places where Kangri is used, like Kashmir. And there is a traditional fire pot, earthenware with ignited coals in it. And this is used by the residents there to keep themselves warm. So they keep it near thigh or near the abdomen. And due to this heat, increased heat, the heat induces the squamous cell carcinoma in those people. So this is known as Kangri cancer. So again in Kangri cancer is squamous cell carcinoma. And oral squamous cell carcinoma, for oral SCC, again oral SCC, the oral cavity is lined by the non-keratinized stratified squamous epithelium, and the risk factors for oral SCC are tobacco smoking and betel nut chewing. So these are the important risk factor for the squamous cell carcinoma that you must know. And since the pathogenesis of squamous cell carcinoma is multifactorial, genetics play a important role. So there is condition, autosomal recessive condition, which is xeroderma pigmentosum. So there is mutation in the DNA repair genes in this condition, and because of this, again, when there is sun damage and other risk factors, the patient will be more susceptible to cancers like squamous cell carcinoma as well as basal cell carcinoma. And again, mutations in the TP53, if it is there, P53 gene is known as the guardian of the genome, and when there is P53 mutation, if there is DNA damage, generally P53 gene helps in the removal of the abnormal cells. It causes the apoptosis of the abnormal cells and prevents their proliferation. But if it is mutated, there will be proliferation of the abnormal cells and there will be decreased apoptosis of those abnormal cells, so leading to the formation of the precancerous lesion of the skin and ultimately leading to squamous cell carcinoma. So you need to remember these genetic conditions as well. One is mutation of TP53 and second is xeroderma pigmentosum. Next we come to the important part, that is morphology. So in morphology, the squamous cell carcinoma is seen, they are seen as nodular growths that may ulcerate. So here you see this is the normal skin and here there is this ulceroproliferative growth. This is the growth which is exophytic. It is grown upwards, as well as some infiltration is also there. So this is ulcero-infiltrative and ulceroproliferative growth, and the cut surface is grayish white and yellowish in color. And this ulcerated lesion, they are generally surrounded by indurated borders. So grossly, this is the appearance for squamous cell carcinoma. And in the microscopy, we see the atypical squamous cells which are proliferating. There is marked dysplasia involving all the layers, and then there is breach in the basement membrane. So these atypical squamous cells, they grow down in the form of nest, sheets, lobules. And these atypical cells, they are pleomorphic. They show nuclear and cellular pleomorphism. They show variation in the size and shape. Then they are hyperchromatic. Then vesicular nucleus with a prominent nucleoli is seen, and abnormal mitosis is also seen. So you see here, these are the squamous cells which are hyperchromatic, pleomorphic, and these are showing, these are invading the dermis in the form of these nests. And you can see there is mitotic figures also, and the cells, they are pleomorphic in appearance, and these again the mitotic figures. So generally we grade the squamous cell carcinoma on the basis of the keratinization. So you know that the epithelium of the skin is keratinized stratified squamous epithelium. So it is a property of keratinizing. So when the property is retained, that those tumors, they are considered to be more differentiated than when this property is lost. So we say that if the tumor is producing more and more keratin, then it is well differentiated, and when the keratinization is decreasing, then the grade is moderately differentiated, poorly differentiated, and ultimately undifferentiated. So in well differentiated tumors, there is keratin production, and that keratin production can be seen in the form of keratin pearls. So in keratin pearls, there is extracellular keratinization. These are the keratin pearls. So there is extracellular keratinization, and this keratin is surrounded by this atypical squamous cells. Apart from the extracellular keratinization, there will also be intracellular keratinization. So this is well differentiated SCC will be producing a lot of keratin. Then moderately differentiated, it produces lesser amount of keratin than the well differentiated, and individual cell keratinization will be seen like in this picture. The individual cells, they will be having a central nucleus and abundant cytoplasm which is dense eosinophilic. So keratinization will be seen in the intracytoplasmic location mostly. There will be lesser keratin pearls as compared to the well differentiated. Then in poorly differentiated, the keratinization will be very scarcely seen. So it has the least amount of keratinization, and the keratin pearls are not seen in case of poorly differentiated. And sometimes to differentiate for poorly differentiated tumors and also undifferentiated tumors where we don't find evidence of keratinization, we may use immunohistochemistry for the confirmation of diagnosis of SCC. The markers like P63, P40 can be used. So basically, there are difference in the well-modeled and poorly differentiated tumors. It is the degree of keratinization, which is most in case of well-differentiated tumors and least in case of poorly differentiated tumors. So these are the three grades. Now, lastly, the bad prognostic indicators in the case of SCC. If size is more than 2 centimeters, then it carries a bad prognosis. Poorly differentiated tumors with very low evidence of keratinization, they are also having a bad prognosis. Well differentiated, they have a better prognosis. Perineal invasion in nerves which are more than 0.1 millimeter diameter, again it is a bad prognostic indicator. Then if the individual is immunosuppressed, carries a bad prognosis. And lastly, the depth of invasion, if it is more than 2 millimeter, it carries a bad prognosis. So these were other important points that you need to include in a note if it comes on squamous cell carcinoma, cutaneous squamous cell carcinoma. Any questions are welcome in the comment section. Thank you very much.